Hi, today I would like to talk about the classification of prerenal, intrarenal, or you call it intrinsic, and postrenal acute kidney injury. This one is a very common table you're gonna see everywhere, but I'm gonna discuss them one by one to let you understand why we have it, how come it's this value, and how to interpret it. So we start with pre-renal AKI. Usually I like to give an example. So let's imagine you have a patient is having a very severe dehydration or hypothermia. So you're gonna have low blood volume, right? So when your body is facing such situation, the blood flow is more gonna flow to the heart and brain, and there's going to be relatively lower blood flow to the kidney, and your kidney sense that. So your kidney sense that you're having a low blood volume, so it's gonna trigger a series of mechanism, but it's not the topic here. But anyway, it's gonna trigger a mechanism, and then your kidneys will try to reabsorb sodium and water as much as possible. So here, your kidney sense you need more sodium and water. So more reabsorption means they are lower urine sodium. So you have lower than 20 milliequivalents per liter of sodium. And this one is easy, right? So once you understand why and there's gonna be a low urine sodium in a prerenal AKI, you can also understand why the fractional excretion of sodium is going to be lower than 1% here. To understand it deeply, you have to look at the formula of it. So the formula of the fractional excretion of sodium here is the sodium excretion divided by the sodium filtration. And each of them, the sodium excretion is the urine sodium times urine volume. And the sodium filtration is the serum sodium times the urine creatinine times urine volume divided by the serum creatinine. So when you put them in the formula, you have this one here. So this one is a divided. So when you see divided and there's a fraction here, so you're gonna reverse the numerator and the denominator. It means, when I say reverse, it means the urine sodium times urine volume is gonna be times serum creatinine, as you can see here. And this part goes to the denominator here. Okay, then we cross out the same urine volume here. At the end, we got the formula here. So you can just look at here to decide and to understand why this lower or higher than 1%. Excuse me. So back to our prerenal AKI, it's gonna be lower than 1%. And we understand it's gonna be a low urine sodium, right? And then a low urine sodium, here low, and then you can already understand why it's gonna lower than 1%. You have a low value of numerator, so it's gonna be lower than 1%. And your urine osmolality is going to be a high osmolality. As I mentioned, you're having trying hard to reabsorb sodium and water, right? So you're gonna have a very concentrated urine, and a high urine osmolality means you have a very concentrated urine, and this part is very clear. And then the serum blood urea nitrogen to creatinine ratio. So the urea is gonna absorb by the urea is freely filtered by the glomerulus, and then even though it's freely filtered, but the 30 to 70% of it is gonna be reabsorbed by the tubules. So it is a prerenal situation, but your kidney function is kind of still intact. So it's still able to reabsorb the urea, and then the creatinine is still freely excreted. So the numerator is urea. The urea, you have a high urea. I mean relatively higher than creatinine. I don't mean or abnormally high. I mean if you just look at the ratio, so relatively high. So then you have the answer of why it is higher than 20:1 ratio. So this part is clear. And then the urine specific gravity. The specific gravity, the normal range is 1.005 to 1.03. So in this case, it's a high gravity. It means it's rather dehydration, or you have presence of large molecule in your urine. But in this case, we know, like we combined with other lab results, we know this is, and then you also have to observe in the clinic for the physical, like the physical examination, so you can come up with a conclusion of this is a pre-renal situation. So it's due to dehydration or hypovolemia, etc. And then still you have to look at the urine sediment. It's going to be benign or high in class. So the high in class is formed by the precipitation of mucoprotein in renal tubule due to a low urine flow. So now you understand low urine flow. It must be because of the any pre-renal situation. So you can come up with a diagnosis of this is a pre-renal AKI. For the intrinsic AKI, the lab value varies. So I give 3 examples here. Actually, these 3 examples, they are very clear if you just look at the urine sediment. So if you find any of them, usually you can just straight to the answer of which problem it is. So if you find that is a muddy blanc class, I think you heard it everywhere. So the muddy blanc class is formed by is not formed. I mean, it's made up of by the cellular debris of tubular cells or ribosome, or sometimes you can even find the tubular epithelial cells in the urine. So you can almost confirm it's acute tubular necrosis. So similarly, if you see red cell or dysmorphic red cell, it means the shape is irregular. It's not the original shape, or some red cell class. You can confirm this is acute glomerulonephritis. I mentioned this one in my previous video. So if your glomerulus is damaged, you're gonna have blood leak out. So of course you're gonna find red cells. And then the last one, if you see that white cell class, and this one is sometimes, you may not see it, but if you find it, it's very clear, then this is acute interstitial nephritis. So back to the lab value, we start from here. As I mentioned, and I repeat, the sodium is being reabsorbed in tubule. So if there's a tubular necrosis, the main function of it is gonna be unable to work anymore. So your kidney failed to reabsorb sodium and water. So you're gonna excrete, your sodium is gonna excrete within the urine. So you have a high value of sodium here. Once you understand it's gonna be a high urine sodium, then you can also understand why it is higher than 1%. Back to the formula. If it is higher, back to formula. So we have a high urine sodium here. You're gonna have a higher value, larger value of denominator, and then you're gonna have higher than 1%, which is here. Clear? It's very clear. And then for the urine osmolality, as I mentioned before, and then the tubule is responsible for the reabsorption of sodium and water, and it means your kidney lost the ability to concentrate the urine. So a low osmolality means you have a dilute urine. So it's very clear you have a low osmolality here because of the urine is unable, because the tubule is unable to concentrate the urine. So the blood urea nitrogen to creatinine ratio I also mentioned in previous slides, I said the urea is freely filtered by glomerulus but reabsorbed by the tubule. So your tubule is not functioning anymore, so you have a relatively lower value than the creatinine ratio here. So it's gonna be lower than 20:1 ratio. And then the urine specific gravity is low. So when it's a low gravity, it means you have a dilute urine. And I explained it in the urine osmolality before. So it's very clear, it's very easy to understand why the gravity is low. So usually when it's low, it means a very dilute urine. So despite kidney failure, you can also find it in diabetes insipidus or someone using diuretic drugs. And then the next one is acute glomerulonephritis. Different from the acute tubular necrosis, the urine sodium is gonna be low in this case. Why? Because if you still remember the anatomy of the nephron, so I hope you can understand by my poor drawing. So this one is glomerulus, and then the blood flow from here to the tubule, descending, and then the ascending. And then here is the distal convoluted tubule, and here is the collecting tubule. Anyway, what happened? What have a problem is here, right? The acute glomerulonephritis, you have damage here, right? But you still have intact tubule. They're going to be damaged, but this is a late stage thing. So when it's a late stage, so there's going to be inflammatory cells happen there. It's causing damage, right? So those inflammatory cells is going to flow to tubule and causing further damage. But it's a late story. But it's a later stage. But here, so it's still intact, right? So the tubule is still able to reabsorb sodium. So that's why we have a low urine sodium here. And then you understand there's a low urine sodium, then you can also understand there's a low fractional excretion of sodium because it's low, and then a lower value of the denominator, and you're gonna have to be lower than 1%. Yeah. And the urine osmolality is gonna be variable. Yeah, as I mentioned, during the late stage, the tube is gonna be damaged too. So it really depends. When this one is still intact, you may have relatively high osmolality, but with its damage, you're gonna have a lot lower osmolality. So it depends. And then the serum blood urea nitrogen to creatinine ratio is gonna be higher than 20:1. So yeah, your tubule is still intact, so you're still able to reabsorb the urea. And then the urine specific gravity is gonna be low, so it's gonna be it's gonna be a dilute urine. You can find it in a kidney failure case. So, and then this one I already explained before. And then move to the third one. It's acute interstitial nephritis. Many value of his here is variable because because if it's in interstitium, it means you don't know, it depends on the damage is happening in the tubule or the interstitium or both. So the situation can be depends. So I'm afraid this one is highly relying on the urine sediment to make your diagnosis. For the final part of the postrenal acute kidney injury, the causes of this one can be the obstruction of the bladder, urethra, ureter, the renal pelvis, or in men, gonna be benign prostatic hyperplasia, or some patient they're using the anticholinergic drugs and leading to urinary retention. So this gonna cause obstruction and further causing damage to the kidney, which we call it the postrenal AKI. And then you may find that already that I put on the value I put on the table, many of them are variable. So it really depends on the stage of the obstruction. So we're going to draw a graph here to try to explain what happened and why. So this one is the kidney. Here is the kidney. Here is the kidney, and here is the bladder. And then in the earlier stage, let's say there's obstruction in here, and then there's obstruction here, and then in early stage, your kidney is still kind of intact, so it's still able to reabsorb the sodium and water. So you may find a low urine sodium in the early stage, but in late stage, the persistent obstruction is gonna cause a high retrograde. Retrograde means from here back to the kidney, reverse direction, retrograde. A high retrograde hydrostatic pressure back to the urine and causing damage to the kidney. So the damage to kidney gonna damage the tubular function. So your kidney cannot no longer reabsorb sodium and then water and then to concentrate your urine. So you're gonna find a high urine sodium, and then of course affect your fractional excretion of sodium. Here I would like you to try to figure out by yourself what happened to this percentage in the early and late stage by using that fraction. And then you're gonna have lower urine osmolality. This one is actually variable, but it's typically decreased. And some set is 350 and some set is 400, and I find this value from a reference book, so I put it's gonna be lower or equal to 400. And then to the serum, blood, urine, nitrogen, creatinine ratio actually is variable too, but it's variable, but it typically remains within the normal range. So I'm afraid you have to memorize this one. So, and then the urine specific gravity is also variable. So as I already explained why it's variable, so it depends on the early stage or the late stage. So in the early structure, the gravity may be relatively high as the kidney is attempt to compensate for the pressure generated by the retrograde pressure by the obstruction. But the late stage, the kidney is damaged, and then there's tubular damage, and then there's a compression of the renal vesicle, so the lost ability to concentrate the urine. So you're gonna have a low gravity. And then for the urine sediment, you're gonna find rather normal cells. If it's normal, it's probably in the early stage. And then in the late stage, if there's damage done to the kidney, it's going to be a red cell, white cell, or even crystal. So this is the end of my share. I hope it helps, and thank you very much for your listening.